have a speaker who's going to talk about zero suicide, a model for community transformation. In 2001, the Behavioral Health Services Division of Henry Ford Health System set out to radically transform its mental health care delivery system by participating in the Robert Wood Johnson Foundation's program Pursuing Perfection National Collaborative. This perfect depression care, sometimes called PDC, initiative leveraged the power of a bold goal, eliminating suicide, to achieve dramatic and sustained reductions in patient suicide as well as improved performance of the entire delivery system. The goal of zero suicides has since become an international movement. Dr. Edward Coffey will provide details about how to achieve perfect depression care. He's a neuropsychiatrist, president and CEO of the Menninger Clinic, and tenured professor of psychiatry and behavioral sciences and neurology at the Baylor College of Medicine in Houston, Texas. He earned his undergraduate degree in psychology, Bachelor of Science degree from Wofford College, a Phi Beta Kappa in 1974, and was then awarded a Rhodes Scholarship to attend St. John's College, Oxford University, where he received a Bachelor of Arts degree in psychology, philosophy, and physiology in 1976. He earned his medical degree from Duke University and was named to the organization AOA, the Medical Honor Society, in 1979. And he subsequently completed there his medical internship and residencies in neurology and psychiatry. Dr. Coffey has held faculty and leadership positions at Duke University Medical Center, Allegheny University of the Health Sciences, and Henry Ford Health System, and Wayne State University School of Medicine, where he was until 2014. He was then recruited to the Menninger Clinic in 2014. Dr. Coffey has also made important contributions to the fields of neuropsychiatry, brain stimulation, brain imaging, and brain aging. He is the author of over 130 scientific publications and book chapters, and he is the editor of several influential textbooks, including the Textbook of Geriatric Neuropsychiatry, now in its 3rd edition. Dr. Coffey also serves on the editorial board of several medical journals. He is the recipient of numerous academic distinctions, honors, and awards, including the American Neuropsychiatric Association's 2016 Gary J. Tucker Award for Lifetime Achievement in Neuropsychology, the highest honor awarded by that association. And one other piece of information that was not included in the resume, but you should know about, is that he paid most of his way through college as the lead singer in a rock group. Dr. Coffey?
You know, the minute you think you're around friends and you let your guard down for a second, right? They just move right in. But it's a great pleasure to be with you here today. This event has given new meaning to the phrase "sing for your lunch," and it's a lot of fun sitting up here eating in front of some 100 people. You know, as the food goes all which way. But it has been a pleasure to be here the last day and a half. You've had, I don't know if you know this, but a phenomenal convening of nearly 150 community organizations, leaders, teammates, team members from a variety of sectors, healthcare and public health and elsewhere, that have been having a conversation around an audacious goal of eliminating suicide in your community. It's really pretty spectacular. And you have the potential to take that initiative and transform, I would argue, the entire health of your community and your state. And I'm so geeked about this whole thing. I've been taking notes nonstop. We haven't slept for 36 hours. We're all up all night talking about ideas. And I will take a lot of this back to Houston because we are preparing to launch in Houston an initiative to make Houston the healthiest city in the country. So there's a challenge now to Madison to see if we can who can get there first. In terms of participation in the conference the past 2 days, I do want to recognize a number of people who are here today, beginning with Joe Parisi, the Dane County Executive. Joe, would you please stand? And we'll have everyone stand. Also present were Dean and St. Mary's. Anybody here from Dean and St. Mary's? Right. Group Health Cooperative. Journey Mental Health. And as it turns out, Ron and I were colleagues back at Henry Ford. So it's a small world. Ron, great to see you again. Unity Point Health Meritor, Meritor, and then UW Health. So I just want to give these folks a shout out and appreciate them for their support of that conference that's been going on. All right, so I'm going to begin with a disclaimer. I'm not an expert in suicide. I got into this business through a back door, which I'll say more about in a moment. But why is it important to you as community leaders? It's important because you're behind the curve. This slide shows the green line is the rate of suicide in the United States over the past many years. It comes straight from your community website. The bad news here, of course, is that the suicide rate is increasing. After decades of it being stable, it's been increasing in the last decade to decade and a half, especially among middle-aged white men in particular. Now, the blue line at the top, above the green line, are the data from Wisconsin. And so your rates of suicide are higher than the national average, and they've been going up significantly as well. So this is a real issue. It's a real issue. You're at around 13.5 per 100,000 at this point. And these are the data, hard to see, I think, by county. The point is that some counties, like Dane, are doing quite well. The rate is lower than the state average, but other counties are doing much, much worse. So there's great regional variation, even within the state, in terms of the rate of suicide. So there's a real opportunity here to make a big difference. And as I hope I'll be able to show you in a moment, it's possible, number one, and number two, the pursuit of zero suicide can transform your entire health community. It's really remarkable. So the work began back in the year 2000 when on a Saturday morning I'm walking into work at Henry Ford. Gail Warden was coming in at 6:30 in the morning, Joe. You know, the CEO was coming in at the same time. And I'm trying to, avert his gaze so we don't make eye contact. But he sees me and he comes over and puts his arm around me and said, I've got something for you. And whenever he said that, you knew you were in trouble, So Gail was the chair of the task force of this report. It's a report from the Institute of Medicine. And he said, look, I want you to take a look at this for me. Just take a quick look. And that means, of course, read it and then send him a written report within 24 hours. This is Saturday. Okay, I'm dying. And anyway, I started reading it, and it was absolutely spellbinding. I could not put it down. I consider it the most important document in American healthcare this century. It's not technical, so if you have an interest, you can get a copy of this. It's an easy read. I'm going to give you the Cliff Notes version right now. The report begins by basically applauding the tremendous dedication and hard work and smarts of the healthcare workers. We have great people in healthcare in this country, very dedicated, very hardworking. The report also acknowledges the tremendous advances that we've made in our understanding of biological science and health in general. So we really do know a lot more about health and wellness and about illness as well. But despite the great people and despite the great knowledge, the care of the patient at the bedside in this country is mediocre. By any statistic that you pick, it is at best mediocre. And the gap between what's possible, given the great people and the great knowledge, and what's occurring, what's actual, is the chasm that's referred to in the title of the report. And the report goes on to say that tweaking the edges, tweaking the margins, nibbling at the edges isn't going to fix the problem. We've got to blow the whole thing up and start over. Back in Detroit, we use a lot of car metaphors, so I'll apologize for that in advance. But one of the ones that I love is that there are no Toyotas in healthcare. Now, this was a lot more powerful before Toyota began having its problems, of course. But the point is that you have a company like Toyota that is very focused on quality and safety, something that our health system has not done a good job of. There are no Toyotas in healthcare. And then at the same time that the CHASM report came out, the American Psychiatric Association took a similar deep dive into the mental health care delivery system in this country and came to the exact same conclusion. It's a patchwork, it's in shambles, it's a relic, it's got to be torn up and start all over. Now, what makes the report so great, in my opinion, is that it did not stop with simply pointing out the problems, right? I mean, that's the definition of whining, right? Here's a problem, and there's no suggestion for what we can do about it. I don't have many rules in my department, but one is no whining, okay? You know, I want to hear about problems, but please, if you bring one forward, have some suggestion for what we might do about it. And this report did so. It laid out a roadmap for how we could begin to transforming the American healthcare system. And the first stop on that roadmap is a conceptualization of what quality would look like. In fact, it went beyond quality to perfect care. What would perfect care look like in this country? And the team identified 6 dimensions. The care should be safe. We shouldn't hurt people with the care that we're giving. Imagine that. Let's don't hurt anybody. By the way, do people get hurt in American healthcare? The estimate is 100,000 deaths a year from medical errors. That's probably an underestimate. But 90,000 a year. Don't go to the hospital. Seriously, if you don't have to. It's not a safe place. The care should be effective. It should work. We shouldn't do things that don't work, and we shouldn't apply things that do work in the wrong situations. An example would be giving an antibiotic for an ear infection in kids, most of which are viral. So antibiotics don't work. They wipe out the good bugs in your body and leave you with bugs that are resistant so that when you really do get ill, you're in trouble. The care should be centered on the patient. Who is the care centered on currently? The providers. The schedule that you get, the clinic appointment you get, is based on my schedule, not your schedule. What a service industry, right? And of course, it should be timely, efficient. Do we ever waste anyone's time in healthcare? Yeah, it's painful to hear this laughter, but it's so true. And the care should be equitable. Every person, every single person, regardless of their age, their sex, their gender, their race, their religion, any demographic you can think of, every person should get perfect care. So this was the concept, this was the model that the CHASM report outlined to use as we begin the re-engineering. And then it outlined 10 rules for how we might begin to redesign that care. I like the first one. Care is a relationship. It's not a visit. It's not a prescription. It's not an operation. It's a relationship. It's customized and it's centered on the patient. The patient gets the care he or she wants and needs when she wants and needs it every time. Every time. We share knowledge. We manage by fact, and the others you can see there, including embrace transparency. Embrace transparency. So we're beginning now to make our mental health record open. It's called Open Notes. Patients will write in the chart right after the doctor. They'll comment on what the doctor just wrote, whether they agree or disagree, and it's available for everyone to see. So when the report was, I was totally geeked. I sent Gail back about a 5-page summary, and I thought it was phenomenal, and said, look, I'd like to get involved in this somehow. He said, well, hang on. And then about a month later, the Robert Wood Johnson Foundation, along with the Institute for Healthcare Improvement, announced an initiative called Pursuing Perfection. And it involved basically offering grants of around $2 million to any health organization that could take the CHASM report and use it as a roadmap for transforming its own healthcare system. Now, the catch was you had to do it in 2 years. So if you know Don Berwick, the head of IHI, former head of Medicare, he's not a patient guy. And he understood correctly that if we continue at the current incremental pace, we're never going to change this thing. We've got to do something dramatic, and it's got to be quick, and it's got to be in our lifetime. It can't take decades and decades to change. So the goal was to change quickly. There were about 3,000 applications downloaded. 300 applications were finally submitted. Most folks, when they read the fine print and saw the 2-year requirement, said, this is not for me. But we were going through a lot of tough times at Henry Ford then. I mean, we had just gone through a big round of layoffs in response to reimbursement reductions. This happened, of course, across the country. And morale was really in the tank. And I had just gotten there myself. I was struggling for a way to try to find something to galvanize the team and re-engage the team in the work that's so important around making people's lives better. So we applied for it. There were 25 semifinalists and 12 finalists. We were one of the 12 finalists. We were the only mental health application in the entire bunch. The others were the usual suspects, congestive heart failure, diabetes, MI care. All these are important, of course, but mental health often left out. And our focus was on depression care. We were going to perfect our system of caring for people with depression using the roadmap that I just showed you. So just a word about Henry Ford. I know that we're neighbors, so most of you may know about this organization. It's very large, $4 billion company, multiple hospitals. We own and operate our own insurance company. And I'm also proud to say that Henry Ford won the Baldrige Award back in 2011 after 7 consecutive applications. We just wore them down. We weren't going to give up. But you do learn from, if you haven't applied, it really is a great experience. And it's the experience, of course, of the application that really is the value. You learn so much from the feedback that you get. But in the awards letter we got, they singled out the Perfect Depression Care Initiative as the example for innovation in the entire health system. So we're very proud of that. So why did Berwick and the team insist on perfection? Why isn't good enough good enough? What's wrong with just being the best? One of my friends said, what does it mean to be the best in a mediocre industry? I told you earlier that our care is mediocre. One of my other friends calls it the cream of the crap. And being the best, certainly not being better, is not good enough. It's not good enough in American healthcare today. So the notion was we're going to pursue perfection. Why is perfection important? Here's some interesting statistics. If 99.9% accuracy, 99.9% is good enough, 2 million records will be lost by the IRS this year. I hope mine's one of them. What's the accuracy rate in American healthcare? People have actually looked at this. It's around 60 to 80%, depending on what you're measuring. This is 99.9%. The autos in Detroit would laugh at us. They're at 6 sigma, 99.99999. And they said, we don't know how you guys stay in business. If we were operating at your level of accuracy, we'd be out of business in a day. 12 babies would be given to the wrong parents if 99.9% was good enough. 18,000 pieces of mail. I don't even know if the mail service moves that much mail anymore. And of particular interest to me, 2 landings at the Houston airport today will be unsafe if 99.9% is good enough. And we're at 80%. So that's why we're doing perfection. And why depression? I think you folks know. It's common. 15% of the population, 25% in a lifetime. It's expensive. It's serious. People die from depression, suicide being one cause of that. A recent article in the Wall Street Journal. And then at about the time we were launching this initiative, we had a horrible death in Detroit. I don't know, any of you who may know this gentleman may have known this gentleman, Heinz. Heinz moved here to this country, moved to Detroit back in the day with a nickel in his pocket and became a gazillionaire. He basically invented the moonroof for the cars. And obviously did very well, and became a major philanthropist in Detroit. And his wife came home one day to their mansion, and he's hanging in the foyer from a power cord from the vacuum cleaner. His wife didn't even know he had depression. And he was being cared for in a major university hospital nearby. That actually has a depression center. So this is the problem. This is the problem. So the grant required the recipient to come up with a definition of perfect care for each of the 6 dimensions that I showed you earlier. So what would perfectly safe care look like for a person with depression? Effective care, patient-centered, and so on. And you had to conceptualize those goals and be able to measure them and then drive to that goal. So with regard to safety, and these have to be audacious goals, perfection goals. So our goal with safety was we were going to eliminate inpatient falls. Not reduce them, which is what we do in healthcare all the time. You know, we're 5% this year, 5%. We're going to eliminate inpatient falls. We're going to eliminate medication errors. In fact, we wrote a contract to our patients. If you come to Henry Ford, you will not experience a medication error. Not that we have the best rate or the lowest rate. There ain't no medication errors. I mean, that's what we're talking about here. So we were okay with that. But we were struggling with what would effective care look like? What would perfectly effective care look like? And we just couldn't make any breakthrough on this, so we ended up going with the usual metric, which is a reduction in the depression severity scores by 50%. This is what all research uses. This is what the government uses to approve a new medication and so on. And so we proudly declared we would reduce depression scores by 50%. So Berwick and his team come down for a site visit prior to awarding the grants. And we had a room about this size with this many people in it. All the system leaders, Joe were there, Gil Ward and the whole group. Don Berwick and his team have flown in. I'm making the same presentation. I'm about 10 minutes in. And I proudly put up the fact that we're going to lower depression scores by 50%. Now, the site visit is scheduled for a full day. It's 8:35, it started at 8:30. All my bosses are sitting in the front row. Berwick raises his hand and says, "Ed, could I talk with you for a second?" And walks out the door. It's 8:35. So I just kind of robotically walk out the door behind him. And he's a good friend of mine, I know him very well. He said, "This is great. Look, we want mental health in the initiative, but if by perfection you're talking about a 50% reduction in depression scores, that's not what we're talking about. So you've got 2 weeks. See if you can figure this out. Resubmit, and then let me know. But we're going to go ahead and go." And they got up and left. It's now 8:40. They're gone, and my bosses are in the front row, and I'm explaining what's going on. It's a true story. So we went back to the drawing board and had numerous breakout groups involving not just patients, but staff, community leaders, family members, trying to get a concept around perfect care. And finally, one day, one of our nurses spoke up and said, "Well, maybe if we were doing perfect depression care, nobody would kill themselves. Nobody would die from suicide." And the room was just as quiet as you are right now. It was like the air was sucked out. No one said anything for what seemed like an hour. And then one of our senior clinicians, kind of a gruff guy to begin with, said, "Well, that's bullshit. We can't possibly eliminate suicide. If someone really wants to do it, how can we possibly stop it?" And that moment transformed our department, because we began a conversation wherein we said, he might be right. If someone really, really, really wants to do this, it may not be possible for us to stop it. But it's not going to happen today, and it's not going to happen on my watch. And if 0 isn't the right goal, what number is the right number for your goal? Is it 50 a year? Does that include your mother or my sister? It's 0. It's got to be 0. So we committed at that point to eliminating suicides. It wasn't our initial goal. It was just part of a depression care improvement project. But it's in yellow here because it became the preeminent goal. It became the galvanizing force behind everything that we ended up doing to perfect depression care. It was just so audacious and so ridiculously impossible that it just kind of turned things upside down. I liken it to back in the day when John Kennedy challenged the country in the space race, right? We woke up one morning, remember, and Russia had launched a rocket, and we didn't even have a space program. NASA did not exist when the Russians fired Sputnik. Now, what would have happened if John Kennedy had said, "I challenge the country to build the best space program in the world"? Who knows what would have happened, right? But what was his goal? What did he say? We're going to send a man to the moon in 10 years and bring him back safely. Didn't even have a space program. NASA did not exist. We're going to put a man on the moon in 10 years, real specific, no question if we get the goal. There's a timeline attached to it, and bring him back safely. So, and the power from that kind of audacious goal, I think, was what helped us in the work here behind a goal such as eliminating suicide. So basically, quickly, what we did was we used an existing model of care called the chronic care model. We renamed it the planned care model. And essentially what you're doing is you're organizing all aspects of your system to create what's called a productive interaction. And a productive interaction is one between an informed, activated patient. So everything you're doing upstream is informing and activating your patient and preparing and helping to be proactive the practice team. So everything you're doing is trying to create that dyad such that when there's an interaction, it's a productive interaction that in theory will lead to improved outcomes. So that's what's shown by the slide. It's much more complicated than that, but I'm just covering it quickly. And as you can see, the two sides here, the informed, activated patient lines up well with those goals from the CHASM report: patient-centered, timely, efficient, equitable care. And likewise, prepared, proactive practice team lines up well with safe, effective, evidence-based care. So it's good crosstalk between the CHASM report and this planned care model. So how do we do? This slide shows you the rate of suicide in our patient population. And because we have an HMO at Henry Ford, in addition to a regular fee-for-service, we can count not only the numerators, we know when something happens like a suicide, but we also have a denominator. We have a population for whom we are responsible, and so we now have a numerator and denominator. We can get a rate, and I think that was part of how we were able to get the grant. So what is the rate of suicide in the general population? I showed you that slide earlier. And the bottom line here in this graph, right, it's about 13 or so per 100,000. So that's the faint line you see at the bottom of the chart. What about if you have depression? What's the rate? It's a lot higher. It is about 20 times higher. That's what's shown by the top line. So I'm sort of showing you the goalpost here. Now, I'm embarrassed to tell you this, but if I ever knew this fact, I had forgotten it when we started this work. What if your depression has been successfully treated, you're no longer ill, you're in remission, to use a technical term. What is your rate of suicide as a group? Does it go back to normal? It's still 5 to 10 times higher than the general population. Now, what do you think we were doing in Henry Ford back in 2001 to manage suicide in people whose depression was in remission? Zero. Embarrassed to tell you that. So here's an example of how this kind of a goal can open up pathways for improvement. So here you see the goalpost. Our rate in our HMO was about 95 per 100,000. Certainly higher than the general population. These are patients, you would expect that. But not as high as that top line. So one of our colleagues said, look, let's declare a victory and move on to something else, right? And we said, no, we're committed to eliminating every suicide. So we began the work in 2001 and have driven the rate down to a rate which is almost at the rate in the general population and have maintained it for over a decade. Now, they said this wasn't possible. And they are the experts in suicide that I called when we started the work to say, look, I don't know anything about this. What advice do you guys have? Many of these folks are my friends. What advice do you have for how we might do this? To a person, the expert said, this is crazy. You shouldn't do it. It's not possible, first of all. It's not possible. You can embarrass yourself. You could jeopardize your career. You're going to embarrass your department. Don't do it. And as my wife knows, I'm hard-headed. We'd already committed, so we got on to the job, and these are the results. So this is absolutely doable. It's absolutely doable. But what it does, even more importantly, is that it lifts the entire performance of your team. People are excited about these aspirational goals. You know, most folks don't wake up in the morning and say, look, I want to go to work today and maybe just make 2 mistakes. Right? No, we don't want to do that. I want to go to work today. I want to hit the walk-off home run today. That's what I want to do. I want to win the game with a walk-off home run. You know what? We're going to strike out every now and then because we're human. Okay? So the challenge here is setting perfection goals, but not beating people up when they make a mistake. We are going to make mistakes. We are human. We make mistakes. But where I draw the line is that we cannot make the same mistake over and over and over again, right? We can't do that. We have to learn. We have to learn. And so it's all about creating a learning organization evaluating the results, good or bad, in a fair, open, and honest and transparent way, and then using that information to quickly improve and continually improve as you move forward. I'm showing you our radar chart here, just to make a couple of extra points. Are folks familiar with this kind of a graphic, the radar chart? A few people are. So the spokes on the radar indicate a dimension of activity. It can be any activity that you have in mind. So at 12 o'clock, we have perfect care. At 6 o'clock, we have financial health. So it can be whatever you want to do. It could be your golf swing, your golf score, whatever you're trying to improve. The green rim at 100% indicates the target, your goal in that dimension, however you've decided to measure that goal. And the red line is your actual performance. So if the red line falls right on the green line, you're right on target, whatever that is, at that point in time. If the red line is beyond the green line, you're surpassing your target, you're doing better. And because each of those rims is a 50% step, you can kind of estimate how far ahead or behind of your goal you are, percentage-wise. So I'm showing you this because one of the concerns was this is going to cost a lot of money. Well, it couldn't cost a lot of money because we didn't have a lot of money. And in fact, our financial performance got better, not worse. We needed some support, some project management support initially to get started. But it was all about making peace with the fact that there's no more money coming into healthcare. We are not going to get an infusion of cash from the government for healthcare. We have got to figure this out. And so let's get rid of the waste and let's improve and get on about it. And so we were able to do both. So it's not quality or financial return. It can't be either or. It's both and. And this work can be done in that kind of setting. I love the story one of our auto execs at Henry Ford used to tell. He described being at a table with all of his engineers back in the 70s when Ford Motor was one paycheck away from going bankrupt. And the engineers were yelling, well, darn it, Alan, what do you want? Do you want a car with good fuel efficiency or a lot of performance? And his answer was, yes. You can't do it. Impossible. Honda's doing it. Well, Alan, what do you want? Do you want a car that's affordable or it's got lots of bells and whistles? Yes. Can't do it. Toyota's doing it. I mean, his point was that if we don't figure it out, someone is, and they're going to eat our lunch. They're going to gain the market share. So we got to get away from this either-or thinking. It's all about both and. So in 2012, the U.S. government dusted off its suicide prevention plan and included the notion of zero suicide in its national strategy. Now, I've just copied here for you how they dealt with the issue of zero suicide. So let's read this. Promote the adoption as an aspirational goal. I mean, how many qualifiers can you have in one phrase, right? Promote the adoption as an aspirational goal. What if John Kennedy had said, well, I really would like to try to get to the moon, and it'd be great if we could do it in 10 years, and it would be really good if we could bring the astronaut back. Right? I mean, come on, So I lobbied long and hard, but, it's politics, and it was hard to get the phrase zero suicide in the document was a victory, but it didn't go nearly as far as I was hoping. And you actually have a statewide suicide prevention strategy. I don't know if you know that. If you Google suicide in Wisconsin, you'll find this. It was just published last year. Your vision is zero suicide in Wisconsin. That sounds good. I'm all over that. The mission is to increase the effectiveness of suicide prevention programming. But then look at the 4 goals. Increase protective factors, increase access, implement best practices, improve monitoring. Are these good things? Of course they are. Of course they are, but they're vague. What's the timeline? And what's the metric? And where's the audacious goal? Right? So I do not mean to be critical. I know how hard this is. I really do. And I know how hard the politics is around setting something that is as ridiculous as zero suicide. But I find that when you tell the man on the moon story, people kind of get it. And I think that's where we are right now in healthcare. We've got to make dramatic improvement in the system, and this is one approach to doing so. Back to your own opportunities here. the collaborative that's been going on the last 2 days is really remarkable. And you have competitors, really, in the market space coming together to try and address a community-wide issue. And they've recognized that if we can figure this out, time is up, if we can figure this out, we can lift, the rising tide will lift all of our boats. It'll make a huge difference in your community. It'll transform your overall health care system, both financially and in terms of quality. And you might beat Houston to being the healthiest city in the U.S. So thank you again for having me here today. I very much enjoyed my time with you all. Wish you good luck with this episode.
Thank you. We won't take questions, but we benefited from the time. So, great. Thanks so much, Doctor. We don't have time for questions, but we had the benefit of wisdom and information. Thank you so much again. Thank you all for coming. Meeting adjourned.